Um, Introduce myself. I'm Damien, not Damien Scarlett. I'm from MSF in Belgium, one of the operational centres we have. There's 5 of them around Europe, based in Europe, and we have regional centres also in other parts of the world. I'm part of the eHealth team. We mainly look after medical data and collection and analysis of it. And as part of that, we have a various suite of tools that we use. DHIS is, of course, one of them. We have Kobo Toolbox and some others around the other operational centres that they use for various purposes. But this presentation, I'll be going through the tracker development for 2 particular health services and 1 project. So we did a hospital-linked tracker program for Mosul, where we have a project there, and also another one encompassing various projects, like a generic-based one that we can develop. So here we go. So we, for the first one, the Ambulatory Therapeutic Feeding Centre or Nutrition Feeding Centre Tracker Program, that's in development. So that's hopefully going to be used across our projects that have a nutrition-based element to it, where we provide that service and we have that we have those beneficiaries in the projects. And then the second one is a more specific one that I've been involved with that is around like a post-operative care hospital in Mosul. I've excuse me, a bit nervous. But for that, I've created 3 tracker programs. They're all interlinked. So there's one for the inpatient, one for the outpatient, and one for the isolation room that can happen after surgery. And next, the main benefits. So the first with the Therapeutic Feeding Centre generic program and the defined indicators. We have a standard list where we provide all our projects with that they should or could follow, and that are reported from bottom up, so from the project to the country and then to the national, international level there. And these have been signed off by medical reference, subject matter experts, and used by epidemiologists as well for their operational research in some particular projects we have. So this is done, but we do have a window of opportunity for projects to tailor their patient of origin or referral locations. Oops, sorry, someone's at the front door. I'll just keep going. And then the second one, other hospitals. So this is for supporting and tracking the patient flow within the hospital. So from their first visit through the OPD first visit, and then the throughput of that, the patient flow, if they go into the inpatient admission area, and then in the isolation room if they have to, and then out the exit, and then further to that if they need surgery in the operation theatre. We also have some ones that we're working on for ICU and antibiotic treatment, but they're a work in progress, still additional ones to do. So for the Therapeutic Feeding Centre, this is a generic one, so we're hoping there are around 100 plus users, including the national, local and headquarter staff. So we're trying to make that as generic as possible, and the spread across how it can be used is high on the agenda of what we're aiming to achieve. The second one, the hospital, that's just for need to know Mosul project stuff specifically, and the medical reference that have their specialisation in emergency care or operational care and surgery related indicators as well. So facilities, locations, around 10 to 15 projects we're hoping for the ATFC. And for the hospital, 1 at the moment in Mosul, but we're hoping we can replicate it in a module-based way to then for other projects with similar hospital functions to utilise as well. And for hardware requirements, so for the hospital, we have NUC, what we call a mini server. It's a form fit mini server that's it's just a small box. It's like a Mac Mini or some other mini server. So that's located in the project, but it's connected via the internal network and synced with our central HQ server here in Brussels. So we do have SSH access to these servers, so that helps with having it located there, and there's no internet. Well, there's a plus and minus. The internet connection is not an issue, but they have to be within the office network to be able to connect to it. And in addition, we have HQ servers based in Brussels. So if some projects have good internet connection, they can utilize what we have here. And we have various servers, so one specifically for data entry and one where the data is synced for analysis. And we also have others like dev, test, training servers there too. Main risks associated with this scale. So again, the conformity with required indicators, what we in HQ, or what HQ requires for their own reporting versus what particular medical activities and services are being required as part of the objective of some of our projects. Also, additional support maintenance for ICT generic issues with these mini servers. So we have another hardware item to look after apart from what we have here in the headquarters. And also, of course, training. So the more we spread our tracker DHI systems around, the more work effort needed to train the staff to properly use it. And our strategy for mitigating risk is uniformity as much as possible. That's a good and bad thing in a way, but we engage and we discuss with all the relevant stakeholders on the benefits of this, and then we listen and try and make a win-win situation from the project's own specific requirements linking with what we need or what HQ needs. So we try and have a middle ground, a pragmatic solution there. Okay, personal and processes. So main stakeholders within MSF primarily. So we go from the regional project location, field location, to the country, and then to the operational centres where we have 5 of them who look after various projects. And then we also have an international level there, which I didn't detail here, but that's the next step up. So pretty much 4 different layers. And within that, we have medical research, operational, logistics departments as well, where we sometimes, the medical primarily we discuss with, and then we have some research and operational links with particular staff in those areas as well. Steering committee with the MOH, we don't really report directly to them, but some of our projects with our memorandum of understandings and agreements with governments, we do report what we do to their national health system. So sometimes we have one system where it's MSF specific, and then another, usually in an Excel file or something like that, that caters for the MOH requirements. And sometimes there's a difference, like the age breakdowns that need to be worked out, but in general, that seems to be working fine. Yep, so we have many Excel files, databases, macros around, too many actually. So we're trying to replace them. They've been designed originally based on the best practice and what's required from the medical reference. And so we're trying to transform Excel files into tracker or event programs as much as possible. Try and centralize the data collection analysis through the HIS instead of having it separate, distributed amongst various Excel files. Strategy for deciding if a program is adequate. So yeah, again, the Excel files are a good reason to implementing a program. There's also different needs from the medical reference. Say they want to focus on a particular medical research area, for example, sexual reproductive health. There's some things that they want to be specific about, either research or for a particular project or two, they want to really focus on the data collection and what's going on there. So we help them with collecting that data, so then they can report through the international organisation that we are part of, and also through their various research, what would you call it, research papers. And then I'm part of the eHealth team, so we all pretty much manage most of the various functions that are required. The workload can be from training to first level support to discussing with medical reference, with operational staff. The list and the breadth is quite wide for what we do in our team. IT support structure, so we have our own fixed internal ICT team. So we have one team for the operational centre itself, and then we have another team for field ICT support. So we do have those links with those two teams. Depending on the requests and the requirements, we can either go through the internal or the field ICT. And also with DHIS being one of many tools that we have, applications, usually we come up with some difficult error messages or issues. So that's when the DHIS sites online, like the community, come in handy. So usually I find Google to be a good helper with that. If typing various words in the search bar, that usually gives me some good information. And then our central IT support team, so they're spread across many demands and what they need to support, so that they're quite thinly stretched. We have actually at the moment one person looking after all our eHealth applications, so that's DHIS and also BAMNI or Open MRS that we have. So it's quite a struggle to provide some IT support at the moment, but we hope to get some more people / money for that over the coming months or years. We host internally our DHI servers, so they're actually on Linux boxes with Docker containers in the nooks and in the virtual servers that we have in the headquarters. So the nooks or mini servers are put in the ICT hardware rack in the project, along with the other ICT hardware items that are there, and then it's connected to the local network and used as a normal server. Combined tracker. Yes, so with these indicators of creating programs for tracker, I've found the counts or the sum ones are quite easy to do, and just with the more ratio-based ones, the bed occupancy rates, the length of stay, and some other ones that require elements from various programs / stages are quite tough to do. I'm finding this hard also, personally at the moment with the therapeutic feeding centre one, like the weight for age and weight for height ones, and of having to present that with each visit of the patient, so that, you know, when they come in and the event is recorded, the data encoder or entry person can see the weight for age or weight for height or a ratio based on previous visits of that patient, linked to their nutrition health status. So with Tracker, as I said, we have other systems in place. At the moment, they're all siloed. They don't really talk much to each other. So I've just listed some other ones that we have in use at the moment. There's some others, more proprietary ones that are used in other OCs, but these are the more open source ones that we have. And the backup plan for Tracker system, yes, Excel, the old legacy macro files are always there. So people like using them, they're familiar with them, so it's very difficult at times to wean users from using that. There is the opportunity to export DHIS pivot tables and stuff into Excel. So For myself, I try and highlight that as a sort of a midway, like a halfway mark that they can still use Excel, but try and use DHIS as much as they can. And then with our DHIS, there's daily or nightly backups that we do. So they're stored offline into a networked storage NAS file system. So they're accessible. I think they have every day per the past month is one that's done, and then previous to that, there's the first of the month that's saved. So that's just some detail there. Privacy security, so we need to develop policies pretty much with a security plan. At the moment, we're just piggybacking off what our organisation's ICT security policy is. We don't have anything specific for DHIS apart from where I'll go into later, the LDAP user accounts. So yeah, with our users, they have to have a valid MSF email address, and then we link it with the Active Directory in the back end for them to log in with their email password, and not a specific different one. We do need a security manager, particularly for DHIS. There is one we have, but there hasn't been a real good review of DHIS just yet. So that's on our to-do list. So that's been a good identifier from this academy for me to go forward and see how that can be done. Main risk with privacy security is so how to do the best management of patient data within the GDPR regulations, because we have the server located within the EU. We are bound to abide by the GDPR regulations and what they say. So we do have a data protection officer that's working with us, and it's pretty much a work in progress. But we are mindful of what patient personal data that's collected, especially with the tracked entity attributes that we assign to our tracker programs, and then also the user access management with the LDAP functionality there. Yeah, and then the strategy for mitigating, as I said, with our DPO and also the LDAP. So I'll just keep going. Timelines. So depending on team members and our HR situation, and prioritizing tracker programs in consideration of other DHIS functionalities. So we're hoping these two programs to be available for wide adoption by the end of the year. That's of course going through user acceptance testing, and then checks, and then indicator validation as well, making sure the indicators produce the right results from the inputted data. Training approach, we haven't really thought about that much yet, apart from ad hoc where it's needed, but we hope to build upon what already exists in the DHIS world. So there's plenty of academy online, like the fundamentals, the level 1 courses, plenty of YouTube videos available. So I try and point that for people to have a look at. And training focal points, so sort of like training of trainers, but usually we have, like I think Paul or someone said in the previous session, of having competent people, identifying them in the project or in the country. So that's an important factor, especially with the Mosul work, the epidemiologist there. She was really competent, and yeah, it was good. She did her own research on DHIS. She read up a bit on that, so it was a good interaction, a good constructive discussion that we had when we were creating that tracker program. In terms of evaluations, there's none planned at the moment, still in the development phase. So we hope to do that later on, once it's ready, and then after a year or two, in terms of the program itself and the indicators that it produces. In terms of monitoring, so I have usually a fortnightly, monthly catch-up meeting with the with Mosul and with other projects, just to check how they're going, and usually have a running agenda, action items on what to do and what to work on. That's on a user level, or training level, and we also have it's a basic Prometheus installation on the server side that monitors the CPU and other server aspects of our HQ servers. But that's been pretty much left untouched for a while. It needs to have some attention given to improve. Oh, that's it. Thank you very much.
Oh, thank you. That was really interesting. So this kind of a use case, we didn't spend a lot of time in our examples on, but it's very common from the NGO side and other large organizations to run these kinds of systems where it's kind of managed centrally, and perhaps you have a central server, but you have dispersed groups throughout the world in many different countries that are doing these things. So thanks for laying that out for us. One of the, I guess, a couple of interesting points to me, and then anyone please feel free to ask questions or put them into the Slack. But one was about the nukes in that environment where they don't have a consistent connection. Just curious, is that a strategy that you've already done previously with some other technologies, or is this going to be an attempt to make it work this time around?
We have various, in the last 2 or 3 years, we've distributed and set up probably 6 or 7 nukes within projects. At least that's for DHOS. We have other ones for the BAMNI/Open MRS projects. Yeah, it was a solution to the low resource settings of some of our projects, say especially in South Sudan and other areas like that. The connection to our HQ servers was really slow, so we had to come up with some creative solutions for that.
And how do you handle the syncing? Do they take the server somewhere and do a sync on some kind of regular basis, or what do you do in order to sync that with the HQ server?
We have SSH tunnels,
okay,
or access. So we do at the network level have open ports, I think they call it, to the required one within HQ for the data syncing from the project to HQ. And we also have one outgoing, like the metadata sync from HQ to the project.
Okay. Another thought was you mentioned this is of course in the MSF run site and their data collection, but you do some data reporting to, for example, the HMIS or the ministry system. Is that something that you negotiate with the Ministry of Health ahead of time? Do they put expectations on you? Do you do a data mapping exercise or something to make sure that the data you're sending them is what they want?
Yes, so personally I've had not much first-hand experience with that. It's usually done at the project/country level and with the medical staff there. Often they have their own external Excel files where they capture that data, and then some of it they can extract from DHIS, and others they have separate or additional fields in the patient files in the tally sheets where they collect that data.
Okay. Well, great. Does anybody else have any questions that they want to ask Damien?
Please do.
Okay, and if not now, then of course, feel free to message him or put it into the Slack. Okay, but thanks again, Damien, much appreciated.
Thank you.
Okay, Keshab, and I'm not sure I'm pronouncing that correctly, but are you ready to share with us the work from Nepal?
Yes. Hello, everyone. Namaste from Nepal. So I'm Keshab Deuba and working as a strategic information specialist at National Center for AIDS and STD Control. It's a central of Ministry of Health and Population in Nepal. So today I'm going to present briefly about tracker implementation planning of National HIV program. So we implemented tracker program to cover recording and reporting of individual level data for National HIV program. Because in National HIV program, if the patients, the HIV clients, they need to take HIV medicines for their whole life. So monitoring their status throughout the process is really important for us for evidence-informed response. So there are like many benefits of DHIS2 tracker, but I'll focus mainly on two. One, it is helping us and we are using it, and we are planning to extend additional component into it to monitor the progress of responses, our HIV response, in terms of program coverage, or to monitoring our key indicators status in real time at different levels, from federal, province to site level. And another major issue, we want to use this DHIS2 tracker information-based system to reduce the workload of health workers working at the sites and providing services to the clients, because there are like very few health workers and overburdened. They are responsible for implementing services for other programs as well. So we want to use this tracker system, information system, to feed them required informations to implement services more efficiently and effectively. One, and another one is to save their time. For example, we want to use this tracker data to implement differentiated service delivery of HIV. That means using this DHIS2 tracker information system, the health workers should easily identifying poor performing clients, such as those clients with poor HIV treatment adherence, so that from tracker, they can easily identify those patients and prioritize more efforts during the counseling services. So another issue is they always generate monthly aggregated report manually from paper-based registers. So from tracker, so our main effort is to use DHIS2 tracker-based information system to provide the services more efficiently and effectively, and also want to reduce their time to generate monthly IT report manually and to submit it to national HMIs. And this is another slide that we want to overcome by using DHIS2 tracker, the major challenges of national HIV program. What program required is disaggregated data for evaluation, for evidence-informed response against HIV epidemic in the country. But what happened till date is like we get only monthly aggregated reporting, and the sites, the collects data in the paper-based registers, and they mostly use just for the reporting to the national HMIs. So we only get disaggregated data, and we want to dig down to know any reasons, we don't know it. So we also want to track individuals to avoid duplications issues that usually affects underestimation and overestimation of testing and treatment coverage in Nepal. But the current system is unable to track the individuals and to address the double or triple counting that result in reporting of duplicate cases as independent infections. So we also want to really understand what is working in real time, because lots of resources are invested and lots of interventions are invested to reduce the mortality, to improve the survival, to improve the retention. But this unavailability of disaggregated data and paper-based register, we used to not get to understand in real time whether our interventions are working in the field or not. So even just to get how many people are on treatment, it used to take us like a lot of months. From this tracker, we easily get at least the treatment data, like how many people are on the treatment, who are these people who are lost to follow-up. So before, like in paper-based registers, it consumes most of the time and energy of people working at the federal and province level to provide feedback to the sites, and feedback like the sites also, there's most of the time wasted in just creating paper-based reporting manually. So these challenges we want to overcome by using this DHIS2 tracker-based information system. And to overcome these challenges, we implemented tracker in all HIV treatment centers of Nepal to record HIV testing and treatment data. But that is not adequate because we have TSIS2 tracker-based HIV testing service to record data of HIV testing and the treatment, but there are like different programs and interventions implemented in other components as well. Because in country, we first try to prevent HIV infections among the risk groups. And if someone get it still at the high risk, then we provide testing. And if someone found HIV positive, then we provide them HIV treatment services. And we want to reduce viral load suppress among them and to improve their survival. This is called like continuum of HIV care. So we want to roll out this DSIS2 tracker in all components of a national HIV response. So this would help us to provide quality HIV services to all beneficiaries at each step of continuum of care. So we planned it and we had meetings with several partners who are implementing these different components. And with the help of our technical partners like India, we are planning to roll out this tracker or integrate their components into our system of NCSC. And we plan to integrate this process by the end of 2021. So currently, there are like almost 105 users for already rolled out system. But if we integrate additional component into the existing system, and there will be like more than 300 users at different levels. So currently we have like, as I mentioned, we have like rolled out this tracker in 81 HIV treatment centers in 61 districts of Nepal. And we also plan to use tracker in more than 26 districts for other component as well, so that we can get data from one system, record and report data from one system and integrate it with national SMIS. So these are like expected hardware requirements for our plan integrations. And my IT colleague is also in this Zoom meeting. If you have any queries, we can discuss this later, because my background is in epidemiology and public health. So I'll just describe about the concept. The four main risks associated with our plan integration is to transport of database backup at different physical locations due to huge size. And we have also limited bandwidth on the grassroots level and data center. To mitigate our risk, we are working closely with India, our partners, so that we want to upgrade our data center infrastructure, which is in the process. So for this overall efforts to strengthen information system of National HIV program in Nepal, the main stakeholders are the National Center for AIDS and STD Control, which is called NCSC, which is the Center of Ministry of Health and Population. We have health. We closely work with the Health Information Management Center and also our INGO partners like Global Fund supported, PR and PEPFAR supported INGOs. And we also closely work with the AIDS Healthcare Foundations, GIZ, and also with UN organizations. And we also created a strategic information technical working group with different background from public health, epidemiology, IT, and management, finance. Everyone is there so that they support us, they provide technical feedback to implement our planned information system effectively. And what we really want to replace is, one, we want to replace this generation of monthly aggregated report manually and reporting into the national SMIS. That would greatly reduce the time of health workers working at the site, and they invest more time in recording data electronically and use of data in providing response. And there are like multiple recording and reporting information systems of our partners. For example, if someone is implementing community-led HIV testing, they have one information system. If someone is also providing opioid substitution therapy, they have another information system. So we also want to merge all the components by using DSIS2 tracker. And we want to ensure recording and reporting of national HIV program through one channel. And so that we can follow like how many people we reached, how many people diagnosed with HIV positive. Among those HIV positive, how many of them already enrolled in the treatment, and how many of them are still retained in the treatment. This would help us to plan our response. So our strategy is like we already like tested the generation of monthly treatment report and uploading it using CSV file into the national HMIS. And similarly, we also will use the same approach for other component as well. And the SI unit, which is at NCSC, led by Senior Public Health Administrator, we working at the MN unit, SI unit at NCSC, is leading the process for gathering requirements, configuring program, testing the program with users. And we also work closely with HISP India and other technical partners like GIZ, who also support throughout the process for integration, the tracker with national HMIs or upgrading the system. Sorry. So we have like a team, IT support, which is will be carried out in our support team at federal level. And if we integrate all the components, we may require additional IT experts, especially to support strengthening the security, upgrading of information system, including monitoring of system performance. And there are like, we also want, there are like lots of HIV related data we also receive from laboratories like who can perform viral load testing data. We also have like CD4 related data. They also generate those record and generate report from their system. We also want to integrate that into DHIS2 tracker so that we don't need to collect such information separately from other entities. So we are hosting our system at local data center of Nepal government, which is it's called National Information Technology Center. And we want to combine a lot of other prevention component with national HMIS. And as I informed, we also need to get, because one of the major opportunistic infections among people with living with HIV in Nepal is TB. So TB also have their information system. We also want, if someone enroll in TB treatment, if they diagnose HIV, we also want that data, TB HIV co-infection data into our information system so that we can work and create synergy between different programs. So we also need to combine tracker with other digital system. And we have our backup plan, which is daily in multiple locations automated. We have like some policies, or there is also act, and we recently have like brief policies and about describing sensitive nature of personal individual level data, things to consider while using recording or reporting individual level data at different levels. But we also need to develop several other documents like I got chance to learn like about security plan and others. And we need to add a security lead from different levels of encryption using DHIS2 tracker on database level. And our main risk associated with privacy and security is like it's highly stigmatized disease, infection, and people who are living with HIV also are hidden in society. They are also getting discriminated based on their status. So it's highly sensitive individual level information. So we are not highly confident whether this level of seriousness or awareness is available at the site level among all health workers. This is also very challenging. So our strategy for mitigating this risk is defining different security policies to protect individual level data and awareing and training our users at the sites or the province level at different levels about recording and reporting individual level data, or informing them about the confidentiality and sensitive nature of personal data recorded in DHIS2 tracker. So we plan to integrate additional component and include all the data into the system by the end of December 2021. So we have planned to provide several in-person trainings after the COVID lockdown at different levels to train our provincial government staffs, including the field level staff. And because currently due to COVID restrictions, we have also YouTube channels, and we are also sharing our DHIS2 tracker information system based how to use this tracker, via our YouTube videos using Nepali language, local language, so that the health workers working at the site can view our videos in their free times. We also plan to conduct a TOT to provincial staff. And we are also regularly reviewing data and providing feedback to the provincial staff remotely, and also providing feedback to the sites regularly. So we are planning to conduct evaluation after the end of 2021. So we'll integrate, we have planned our routine data quality assessment, national level routine data quality assessment of all components of HIV program. So we'll integrate our tracker evaluation with that RDQA. And another important thing, what we're trying to showcase is we can use routine health facility data using DHIS2 tracker to generate evidence for informed response, or because we also implement several interventions, we can also use data recording tracker to evaluate effectiveness of interventions. This efforts is also ongoing side by side. So we also monitoring checklists to monitor the tracker based information system. Whenever we visit the field, we have comprehensive monitoring checklist. We also review at the province and reviewer team at the province and the federal level who also review the data and provide feedback to the sites. And we also frequently be in touch with them in Viber and Facebook messengers and inform them about the status and request them to record and report complete quality data on time to the national HMIS as well. So this is the end of my presentation.
Great, thank you very much, Keshab. That sounds like a big and exciting project, and looks like it's been well planned. So I saw one question in the chat about you mentioned wanting to improve and have real-time reaction, and just curious about the specific kind of actions that you would take. What does it mean in this context to do real-time, and what are the kinds of reactions you would want to be able to take?
So real time in terms of we have key indicators, and we have also targets for the different provinces and the sites. And then we monitor those progress in every day. And we also compare if someone reported before using this tracker based information system, they have monthly aggregated data reported into HMIS, they have reported 1200 PLHIV. And then we also monitor by tracker, you reported 1200, but still there are not 1200 on a weekly or in every alternate day. We inform them about the status that at least we want to know, or we are getting how many are on the treatment. At least yesterday, how many of them were treatment, HIV treatment in Nepal. So for that, we are telling this as a real-time status of the country of national HIV program.
Okay, so it's very much from kind of a programmatic perspective of being able to see how the program is operating and understanding how many people are on treatment, those things. Are there also plans to include some real-time kind of tools for the clinicians? Would they use it to generate, for example, a list of those that are lost to follow-up, or those kinds of things?
That's excellent questions, because today I got email from Alice that our abstract is accepted, but we are going to present about that, how we are using this information system to feed health workers. We can monitor aggregated level indicators at the national and province level, but the site level they can also monitor aggregated level status, but also download the individual level, also view and download the individual level data of those clients, so that they can target specific interventions to them. So we will also present this our experience in our upcoming DHIS2 conference in June, I think. Yeah.
Right.
Mhm.
And have you had the chance to work with the users themselves on the design of the system? So it's you have an intention to replace some processes and you wanted to reduce the burden of reporting. Have you had their input on how the system is designed, and will they have a say in kind of how it fits their needs?
Yes, we regularly get their feedback during our provincial level trainings, and we also learn because when we in the beginning when we implemented this program, this to tracker based information system, we were so excited at the central level in early 2018. But after like 4, 5, or 6 months, very few were using our information system and at the site level. And even they forgot about our wavelength for tracker, where to record information. Then we had like assessments, several level of assessments with them, why they are not using our information system. And the most important questions from them, what we receive is why they should use this information system to record data. Because they are paper-based registers, they have like another partner information system. Why you are requesting us to like record that information system into DS2 tracker? They asked, so many of them asked us. Then we realized like, okay, we need to answer them these questions. And then we started telling them, okay, well, you can create, if you record all the information data into the tracker, then you can generate monthly report by just clicking one button. So it will greatly reduce your time. So all these efforts happen by mutual interactions. We always contact them if you want to add or remove any additional variables, or if they want to modify anything, or if they want to any specific indicator into their dashboard. We are also training them how to, especially in the analysis part, how to use this analysis. So is this happens with their close consultations and their feedback. Otherwise, no matter how like good system we develop, no matter how much resources we invest, if we'll not get their feedback, if they will not generate their interest to use it, then it will be not effective. So we learned it in last 3, 4 years.
Yeah, that's great. And we've definitely seen that all over the world, the same scenario where the users themselves are, of course, they're tired of all these new systems. They already have a lot to do, and so it's if you want it to succeed, then you really need to make it worth their while, so that they can actually have a motivation to use the system.
Yeah.
Has there, you mentioned being able to use the tracker data to generate the aggregate report, which is great. It looks like you had approval already for that from the program level. What about replacing any of the paper? Is that part of the conversation? Can they use the system in place of some of their paper registries, or do those all need to continue?
So some of the sites aggressively requested, please replace these paper-based registers, because they have like electricity all the time, they have internet all the time, and they're very few clients. They, in those cases, it's manageable. But to remove that paper-based register in long time, because in long run, because we have sites in remote hilly and mountain areas, even like internet is too slow still till there. And recently we try to use this Android-based app to record report, but even that was like slow. So due to these challenges, so it may take time, because ensuring 24-hour electricity and the internet, it may take time. We have planned it, and we are planning to develop our strategy how we are going to do it. But immediately it may take more than 2 or 3 years, because still some sites, 15 to 20 sites, they don't have like access to electricity or internet 24, at least in whole day, especially in like remote primary healthcare centers.
Yeah, and again, also that's very common in many of the countries that we support. What I have seen as a successful way to do it is to do just area by area. So those places right now that have consistent internet and electricity, they may be the first, and they can be allowed to simply think of the digital system as their data source and their data entry tool. Of course, they can still have the paper that they can use in an emergency, they can use as a backup, but training them to use the system first, and only if they need to would they go to the paper. And then that can change kind of part of the country by part of the country. But I know this is always a very difficult conversation to have with the ministry, and to get people to sign off on it, because they're so used to having these paper forms, and there's a desire for them to be consistent across the country. But just thinking of the poor user themselves doing double data entry, this is one of the key barriers to using the system. So
Yeah. So what is happening is, informally, there in some sites who are like very active and have access to, they are not using paper-based register HMIs. But to make it more formal, we need to have strong plan and to discuss with the HMIs, and we need to convince them this is the reason. Then we can claim it formally. And if you have like any country experience or document or strategy how they replace their paper-based register, please do share with us, and so that we can use it.
We actually did a research trial when we were doing the Palestine system that I mentioned earlier. And the research trial actually compared, it had an intervention site that received the digital system, and then an arm of the trial that stayed on paper. And the sites that received the digital system had a time where they did both, and then a time where they were just on digital. And so they were actually able to show to the ministry, because of that research project, that if the user was allowed to just use the digital system, they actually had more data completeness, and they spent less time. And if they had to do both systems, then they had worse data completeness in both systems, and they spent a lot more time. And then they compared that also to the sites that just had paper, and the digital system was less time than those that just had paper. So we do have some findings on this. This was a part of a research trial that was done. And we have the experience from the implementation team in Palestine. I know that they're always happy to talk with others. And the HISP India team that you're working with, actually one of them also worked with us on that Palestine system. So they may be able to do some connections, but happy to help connect you there.
Okay.
So I don't know, let's see if there's more questions. Yeah, so Paul is just making the point that you should always have an operations continuity and disaster recovery plan. This is absolutely true. And again, this is a part of what we have always encouraged. If you are going to be replacing a paper system, that doesn't mean that the paper disappears, but rather that you always have an option to collect the data on paper if needed. Because you definitely don't want the services at the site to go down because the system went down. And you don't want to lose any data because the system wasn't available. And of course, in addition, Paul's point about having, disaster recovery plans. So I saw from your slides that you have backup sites and plans for all of that. So that's great.
Yeah, we are forcing our partners to invest on server and trying to make one recording and reporting system, because we spend like yearly $13 million, but to get data, it took us like months just to know how many are on treatment. So we are forcing them, and now everyone is agreed and to use. And so we are like started, East India and our team are started working on it. From this week.
Great. So I'm just looking, I don't see any additional questions. Did anybody else want to ask a last question for Keshab? Okay, if not, thank you, Keshab. That was great. Appreciate your contribution. And
Thank
with
you for
that,
giving the opportunity.
yes, it's great to have you.